Okay, so if people could come on in and sit down, we're going to begin our keynote lunch talk. This is going to be a case study on distributed systems for clinical research information sharing. We're going to have Dr. Richard Platt address us, and then we have some time for conversation, discussion, etc. Dr. Platt's a professor and chair of the Department of Population Medicine and executive director of Harvard Pilgrim Healthcare Institute. He's an internist trained in infectious diseases and epidemiology, and he's focusing in his research on multi-institution automated record linkage systems for use in pharmacoepidemiology and population-based surveillance. He's had experiences essentially with every federal agency involved in health, I do believe. So I'm not going to go through all those. They're in your packets. Welcome, Richard.
Okay, thanks very much. So I would posit that just as none of us really cares about good health care except as a way to getting to good health, we don't really care about data sharing so much as we care about information sharing. So what I'd like to talk with you about in the next few minutes is to what extent can we share information while minimizing the amount of data that we have to share? Well, why not share information? We've already talked about, this is a much more condensed list than the one that we've already developed this morning. I would say that on the privacy side, personally, I am a relatively conservative in my beliefs about whether it's possible to de-identify data, but certainly to the extent that we're successful in de-identifying data, it becomes less rich and less useful. For instance, if you say we'll only identify someone at the level of country, that means that you can't ask questions about using census data to geocoded data to do a variety of kinds of mapping. We haven't really talked much about the potential risks of inadvertent disclosure when data is shared, but it to my mind, is a very important one. My colleague Mary Durham likens data that's shared under various confidentiality provisions to hazardous waste, saying once you have it, you then have to be a good custodian of it forever. Now, she and I differ on whether it's like radioactive waste or like biohazard waste. I think it's more like biohazard waste because it can multiply. You can say, that's okay. We have mechanisms for dealing with pathogens, and that's certainly true. With a sufficient amount of effort, you can keep control of it, except when it gets loose. And then you need Morgan Freeman to bail you out. And how many Morgan Freemans are there? Why else? If those reasons for sharing data haven't given you pause, you should certainly be concerned about the threat to litigation that you might expose yourself to by receiving the data. You can say, Rich, you're just being paranoid, and I'll say you're only paranoid if they're not really after you. This is a subpoena that my organization received in February, asking for a very large amount of data. It's not the first time we've been subpoenaed, and although it was quashed, it was a fair amount of effort for the legal team of a large number of organizations to respond to this kind of subpoena. And I have to tell you that in this case, we were using information that came from healthcare systems, and it's always a problem if I show up on the CEO's doorstep to say, don't worry about the subpoena that we just received for your data. So that leads to my second law of collaboration, which is don't take possession of somebody else's data if a third party might want to subpoena it. So what's the alternative? The alternative is the approach that the Office of the National Coordinator for Health Information Technologies has promulgated for sharing of clinical information. And that is to say, this is the Query Health Initiative. It's separate from the meaningful use exchange of patient-level information and is intended to support essentially the learning healthcare system, the informed secondary use of electronic health data that's supposed to transform our ability to learn what works and what doesn't work and assess quality. So this is Farzad Mostashari, who says the mantra should be send the question to the data rather than bring the data to the question. And so I'd like to expand on that theme and think about ways in which we might do that. Well, first of all, what do we mean by the question? Question in this sense is an executable program that can be sent from the originator to the holder of data, and that program can operate on a remote data set without being translated into a local form. So how might that work? Well, the easiest way, this is the way we did it originally, was to have the authorized user write the program, and then we'd email it, or we'd send it on a disk, or sometimes we'd use SneakerNet. And then the person who has the data would run the program and send the results back in the same way. If you need to do a single kind of exchange, that works, but it's very cumbersome to do that. A second way would be to say, let's give you direct access, and you can log into our system and do the analyses. That also works. It means having to, first of all, create the right kind of access through a firewall, which many organizations are hesitant to do, but you can do that. But in a more advanced form, you'd want to build a whole bunch of protections into it. You'd like to know that an IRB has been involved. You'd like a portal that can handle a lot of network management kinds of functions. I won't read them all. And then you'd like local control, so you know who's coming in to ask the question and what kind of question it is. And you'd like to be able to understand whether or not you're prepared to respond to the specific question. But if you could set up a system like this, you could also set up a multi-site system where you had research data from several different organizations behind several different firewalls, and a single question could come from a portal and be distributed to all these sites, and results could come back. And you might say, if I have a sufficiently rich data set, I'll be prepared to create project-specific data to support a specific inquiry from someone with whom I'm prepared to collaborate. A sufficiently rich data set would be one that has many patient-level identifiers, for instance, and it might only be necessary to expose to a remote investigator a small fraction of that information. Now, since I'm mostly not a trialist, this is the way I think of trialists. They're smart, they're elegant, they move well. And it's all true. It's all true. But speaking for the community that uses observational data, I have to think the way Ginger Rogers did, to say, when you're using observational data, you have to do it sort of backwards and on high heels. Because the data is derived from source data that usually comes someplace else and was not collected under protocol, but was collected as part of the routine delivery of healthcare. And so a fully implemented distributed system might be one that uses clinical data as, even for clinical trials, might start with the EHRs. That's part of what we heard about this morning, and be supplemented with research data, and then spin off project data and be accessible through a sufficiently robust system that allows queries to be originated and authenticated and authorized, and then can take results back and aggregate them. Well, does something like this exist? I have to apologize. We've been going from right to left all this time, and now you have to go from left to right. This is an example of the reference software that Query Health uses for what's called its policy implementation layer. My group built this, but we didn't know it was a policy implementation layer until Query Health told us that. But you can see on the left there is a cloud-based system for having people with various kinds of authorizations submit queries, which can be authenticated in a variety of ways, and they're transferred over to a data mart client, which lives with the organization that has data, and that can relay the queries to a data source, and then the results can come back. So the worked example is work that my colleagues and I are doing with the Food and Drug Administration to build a post-marketing medical product safety surveillance system. It's called Mini Sentinel. Mini-Sentinel has 30 organizations that are participating in it. The ones above the line are data partners. There are 17 separate installations that have data that has been acquired during the course of routine patient care, and they're all participating in this work. The Mini-Sentinel distributed database has data now on just over 125 million people, 3 billion dispensings, 2.4 billion unique encounters. So there's a lot of data that's been put into a common data model. Each organization has transformed its data into exactly the same format, so it's possible when you send a program to have that program operate on the data. I was asked to say something about how does that happen, and the answer is it's a simple 8-step process. But I'll just point out to you that if you look here and here, there are these little circles, which means it's an iterative process that we go through. And we do about 400 data checks now on the data, and if the data doesn't check properly, then it has to go back again. So it's not a small process to do this this conversion into common data model format, and the large data partners do this every 3 months or so. So it's an ongoing activity to create this this resource. Having created it, it's then accessible to a distributed data system, which, so here's the cartoon version showing one data partner, another data partner. There's 17 of them. There's a portal. The queries come out. There's a firewall. The data partner has a choice. The data partner can stop every query that comes in and examine the code before allowing it to execute. And the data partner can stop every result before it comes back and inspect that result before returning it to the coordinating center. On the other hand, they can set the permissions so that one or both of those runs automatically, and depending on the kind of query, they sometimes do one or the other of them. By and large, what comes back is aggregated results. That is, it's counts or frequencies or rates. Doesn't have to be, but by and large it is. And although this runs as this is a public health surveillance activity, it conforms with the HIPAA provisions for public health, not for research, and the common rule covering research doesn't apply. Nonetheless, we work hard to minimize the amount of person-level data that's transferred. So almost all the heavy lifting that involves patient-level data is done here behind the firewall of the organization that has the data as part of its regular operations. So here, I'll show you briefly an example of the kind of work that can be done with a distributed system, because I know you're saying, for all that work, nothing substitutes for having the data in front of me and being able to manipulate it and look at the results and being able to use it. As an investigator, it's very hard. Your initial sense is it's very hard to work by remote control. So here's work that we recently completed with FDA, looking at angioedema related to drugs that target the renin-angiotensin-aldosterone system. This is work that's going to be published in a couple of weeks. So I'm not going to show you the results, but I'll just show you how we set things up and how we did the analyses as an example. This looks like a regular research project because it has a big research team that was involved in it. The question was, are ACE inhibitors, angiotensin receptor blockers, or aliskiren associated with similar or different risks of angioedema compared with beta blockers, which is the referent group? We defined a cohort as individuals who were at least 18, who had a first treatment with one of the drugs in this class. If you've already been treated with another drug in the class, you're not eligible. The index date is the first dispensing, and the additional eligibility criteria are here, which is we have to know something about your history. We have to know that you haven't had angioedema in the past 6 months. We have to know that you haven't had any of these other drugs of interest. We know that you have to know that you aren't getting 2 of these drugs, which means we have to be confident we know what your medical history's been for the past 6 months, which means we have to be confident we know essentially all the medically attended care you've received. primary outcome is angioedema, which turns out angioedema is a condition for which a coded diagnosis in a claims file turns out to have a very high positive predictive value. For this condition, it's not necessary to do chart reviews to review them. And the secondary outcome is serious angioedema, airway obstruction, hospitalization. You can see the additional criteria here. So here's the schematic for for the study design, at least 6 months during which we know various things are or are not true, and then you're observed until the date of first angioedema or the end of the study period or these various termination events occur. So you can tell we're getting ready to do an analysis that's sensitive to person time. There are a bunch of confounders. These are the ones that we controlled for. And the analysis includes a descriptive analysis, regular old baseline characteristics, unadjusted and adjusted, and then pairwise comparisons to beta blockers, adjusted by site, propensity score adjusted hazard ratios, and then a case-centered logistic regression model was the primary analysis and an inverse variance weighted meta-analysis. I've asterisked this case-centered logistic regression model because it's an analytic technique that Bruce Fireman at Kaiser Permanente, Northern California, developed in part to minimize the need for moving patient-level data around. One of the things that's become increasingly clear to us during the several years we've been doing this work is if you ask sufficiently thoughtful statisticians and epidemiologic methodologists to develop new methods that can work in a distributed fashion, they can be remarkably creative. So while not every analysis that one might want to do is amenable to distributed analysis, an increasing number are, and I think there's a substantial amount of room that we could still move in that arena. Secondary and sensitivity analyses, so we're doing stratified subgroup analyses, sensitivity analyses, changing the look-back period, restricting to inpatient and ED diagnoses, restricting to the date after the most recent of these compounds was approved. So the point I'm trying to make here is these are the kinds of analyses that we think of as being part of good data analysis, and they're all ones that are reasonable to do in a distributed form. Also, just say a little about how does this really work. So imagine now that we have the distributed data set in all 17 organizations. The request, I showed you a cartoon that shows the data, the query goes out and the results come back. But this is really what happens. The query comes out and it wanders around for quite a while, and it ends up back here. So I won't take you through all the steps, but it's not small work. On the other hand, we are processing hundreds of queries a year now from FDA, and it's possible to do this on something that starts to approach reasonable production levels that can support a national system for post-marketing safety surveillance. Now, what about data sharing? So for the study that I just showed you, by the way, the study that I showed you has millions of people. That is not doses given. Millions of people were involved in, millions of people's data were part of that angioedema study that I just described. No person-level data was shared to do this study. On the other hand, there was, from the perspective of the investigators, complete information sharing. Essentially everything that was interesting in those data sets that could answer this question was accessible and used for to address the questions of interest. So what does that mean? It means to us that it should be possible to address a very large fraction of the questions for which we usually have historically thought it was important to do data sharing by sharing programs among organizations that are prepared to collaborate on doing distributed analyses. And therefore, it'd be possible to have them participate in a variety of kinds of networks. So here's a schematic showing the way the FDA Mini Sentinel operates. But you could imagine that some of those organizations might also participate in an NIH distributed network. And that network could be include health plans, it could include hospitals, and it could include research data sets of the kind that come out of the clinical trials that we're talking about here. Obviously, they have different kinds of data in them, so you can't ask the same question of every data set, and you can't submit the same program to every data set, but to the extent that they either have or can be converted into the same data format, you could use that approach. And you could have a bunch of other networks. You could make your network here. So the logic of this is every organization could choose to participate in multiple networks. Each network can control its own governance, because we talked a lot about governance. Who should have access and what should their responsibilities be? But on the other hand, the networks could amortize the not small costs of infrastructure development, data curation, libraries of analytics, and a whole array of things could be amortized over the whole operation. It's not completely a pie in the sky operation. Last week the NIH announced the creation of the Healthcare Systems Research Collaboratory that Rob Califf is leading. As part of that, there is a plan to develop an NIH distributed research network that would have the capability of communicating with the entire Mini-Sentinel distributed data set, the trials that are funded under the collaboratory, and essentially any data set at any site. So I'll just leave you with a thought that our goal should be to share information and not data, and that if we approach things that way, we might be able to make more progress sooner than we would if we have to nail down all the issues around sharing the data itself. Thank you.